stop tomorrow, the immediate suffering would be overwhelming. People would wait until their health needs demanded emergency room attention, costing the taxpayers. And those who struggle to find transportation would be in worse shape. Angel Oak Family Medicine provides health care that offers personal connection, long-term relationships, and walkable proximity to the neediest people on the island. Jackie specifically has a heart to move the people from passive yet angry entitlement towards the responsible and flourishing participants in society. This mindset is the way to break the cycle of poverty and dependence and truly empower all people to live in health, mind, body, and soul. I am concerned that the way the law stands in this state, Angel Oak Family Medicine is at risk of closure when the physician is no longer providing oversight or is unable to continue. I hear that 30 other states are already functioning without the requirement of the overseeing physician, and it allows for more medical care in rural communities like ours. So I just urge you, because right now I have a doctor that's 71 years old. She may be able to get a call. She might get a call from Jesus, because, God only promises 70 years. And if that happens by statutory law, I am helped. I would have to close my clinic. And the patients that I serve don't have the voices to come out here, and they need the care. And I think I've been there for 15 plus years, and I've made a big impact. When I asked a doctor to come sign the supervisory agreement that the state mandates, nobody would sign it. And I asked why. I have malpractice insurance that's 1 in 6 million. I've been doing this for 15 years. I'm good at what I do. My patients love me. The community loves me. But for me to stay in existence, I need this paper signed. And nobody wants to sign this. I said free of charge, but this is the stumbling block. The law is outdated. And I ask why. Thank you.
Thank you, Ms. Bear. Hold on. Let me see if some members of the subcommittee have some questions. Sarah from Greenville.
Thank you for testifying. It sounds like you do a great service down there. I appreciate it. When you held that up and said nobody wants to sign that, why do you think that is? Why do you think nobody wants to sign it?
It's risk exposure. I have malpractice risk. I carry my own malpractice. And if I were to be negligent, that doctor that is supervising me would be held responsible, because by state law and malpractice lawyers, they want to go after the deepest pockets. And as a nurse practitioner, my pockets aren't as deep. So doctors tend to get sued more often than nurse practitioners at 37%, nurse practitioners at 1.5%. And not only do the doctors get sued, but the hospitals that they work under, which are also on the hook for state monies. So when somebody decides they want to be litigious, they're not coming after me. Even though I might have been negligent, they're going to be going after the doctor that never saw the patient or the hospital that they went to. And so that adds liability exposure. And that's why, it's really hard to find somebody. And I've tried, I've been there 15 years. And just a few minutes ago, I asked, and people said, I want to think about it. But for me to stay open, this little piece of paper needs to be signed. And that's if I want to follow the law. And I haven't had any takers.
If I can ask this, how are you able to render care now without there being a signed supervising physician?
Well, Dr. Rosegib is still alive and well. She's 71 years old.
Oh, I see. Okay.
But God only promises 70 years. So if she gets that call from Jesus,
okay,
by law, I got to close doors.
Gotcha. Thank you.
So I worry all night.
Any other questions? No. Thank you very much, Ms. Bauer, for making the trip for a second time and sharing not only what you said today, but also the materials that you sent to us.
And there was an article done on me, and my patients can't get here because of a lot of reasons. But if you look at the commentary behind that article, they may not have the best English. They can't call their senators because they don't have emails. But maybe you'll get a sense of, it gives you just a snapshot of what we suffer. It's really sad, but I feel like we're holding back healthcare from the people that need it most. And primary care is the bricks and mortar of a good, healthy society. And I just feel like we're not helping our patients here in the state. And I think that, if we do what's right, that we could make South Carolina a world-class state. We have the brains. We can bring the best and the brightest, and we can go from 42nd to first. I'm not a, last person kind of, I just don't like coming in last place. And even I don't want to go there. Okay. But
okay.
But anyway, I've said too much. Thank you.
That's okay. Thank you, Ms. Bear, very much. Yes, sir. Please come forward. State your name, please. Dr. Owens, okay? Good afternoon, Dr. Owens. Appreciate your patience.
Thank you very much. What she's passing out right now is the actual speech I'm about to give, so you can follow it if you like. And the other piece is a CD, a DVD, with lots and lots and lots of evidentiary material on it, which is probably everything you heard in this room today and other days. The other thing is a 15-page brief that deals with breaking down the arguments for and against nurse practitioner autonomy, partial or total, and I sent it to you yesterday, and you can read it at your leisure.
Thank you for that.
Subcommittee Chairman Davis, committee members Corbin, Gambrill, Matthews, and Nicholson, fellow physicians, and ladies and gentlemen. It is an honor and a privilege to speak to you today concerning this important statewide and nationwide issue surrounding South Carolina Senate Bill number 345, which is increasing the autonomy of well-trained, well-credentialed, and properly indemnified nurse practitioners as they willingly and unselfishly seek to fill the stipulated numeric and geographic gaps in the numbers of primary care physicians in this state and nation. Nurse practitioners are resolved to help in A, improving accessibility, B, constraining cost, C, and providing safe and quality health care to potentially all the citizens of this state and nation. Notwithstanding the century-old argument of whether the practice of medicine in America is still an art or rather a more progressive business model, nonetheless, the medical industry in America is undoubtedly the best in the world in the 21st century. It is the model for all the world. People come here if they can afford it. Unquestionably, the medical system in America at all levels, medical, dental, nursing, administrative, research, and pharmaceutical, incorporates the best initial and continuing training, the best medical and surgical practices, the best research and development, the best governmental supervision with credentialing and oversight, and yes, the most malpractice lawsuits in the world. America has lots of trial lawyers and lots of liability insurance to go after. But realistically, even America's medical complex still has many problems. I mentioned malpractice for one. However, this pales with respect to two other most important problems at hand in the 21st century. The first is accessibility of this medical system to all 320 million souls in America. Legislative attempts such as Medicare and Medicaid in the mid-1960s and the 2009 Affordable Care Act, properly known as Obamacare, were supposed to change all that, but they have fallen short with respect to accessibility and cost. I will not take time here to debate the merits of whether health care in America is a privilege or a fundamental right. That is left up to the 9 wise justices on the Supreme Court to decide. However, societal and political pressures in America and the world today are pointing toward health care as a fundamental right. And that begs for and introduces the next problem already mentioned, and that is cost. Regardless of who pays for it, but it must be paid in either a capitalist or a socialistic society. The USA continues to explode its national debt as entitlements consume over 60% of all federal spending. In summary, the future of healthcare technology is still bright in this country, but accessibility and cost of healthcare technology is still, accessibility and costs continue to overwhelm the system until it reaches a breaking point, and nobody quite understands when and how that breaking point will occur, not to mention the consequences to our nation and the world when it finally does happen.
Let me stop you for a moment and ask you a question.
Yes.
In regard to accessibility and cost, I've always looked at those two as being related in terms of accessibility, and as you expand the supply of providers or expand the number of individuals who can render care, then as a function of economics, you're going to see costs go down. Is that your understanding as well, that if you increase the number of individuals that are out there able to provide care, that then as you increase supply and demand remains constant, you're going to see costs go down? Is that a fair inference by me?
I don't think that's a quid pro quo exactly. I would probably look at it in another respect. If you have more and more practitioners, and if they see those patients at the home office, and treat their problems and keep them out of the emergency rooms, then I think you'll have a dramatic savings of medical care, medical dollars. But I don't see otherwise a cause and effect. I don't see a quid pro quo just having lots and lots of primary care providers as bringing down the cost unless they specifically cut them off at the pass, so to speak, see them in the office, and prevent that emergency room visit in the middle of the night.
Gotcha. Sorry to interrupt. Go ahead.
With this preamble of sort, let me focus on the issue at hand. The enhanced and perhaps eventual total autonomy of properly trained and credentialed and indemnified nurse practitioners in their unselfish quest to provide primary health care and thereby help fill the gap left by inadequate numbers of primary care physician providers as forecast by the AMA and other groups over the next 20 years.
All right, let me stop you there for a moment. Tell me about the projected inadequate numbers of primary care physicians. Elaborate on that a little bit.
Yes, sir. The numbers range from 60 to 90,000, I've heard. By 2025, maybe even higher than that, 150,000 or so. It's hard to say because medical schools are looking at this closely, looking at all the assets that are available. Nurse practitioners are there to pull up the slack, to fill the gaps. So I think everybody's looking at medical school curricula and see if they can turn out doctors. When I went to medical school, a large one on the East Coast, we had 164 men, all men. And that's been changed quite a bit now. But medical schools sometimes tend to cut back rather than increase. So I can't really answer your question more than to say that they're trying to keep up with the need. However, I think there are other factors that come into place, the demographics of people, where the geographic areas that they grow up in and so forth. I think there are more factors than just the number of the deficit in family practice physicians. Basically, the nurse practitioners are willing to go to the more rural areas to serve the public well.
Okay, continue. I'm
Mr.
sorry.
Chairman,
Sure. Senator from Greenville.
after having said that statement, I heard studies that said just the opposite. That just because they had independent practice, they did not bleed out into these underserving areas the way that we're being led to believe that they do. I mean, do you have some sort of proof that you can show that if we do this, we're going to all of a sudden get huge coverage?
And I think let me supplement the Senator from Greenville's question, because one of the assumptions that's being made by me and by others in regard to this piece of legislation is that if the scope of practice of nurse practitioners is expanded, then at least one of the effects will be underserved rural areas will receive some care that they're not currently receiving. And so to the extent, and I'm not necessarily asking you to provide it, but to the extent that there is empirical data in regard to what other states have done in expanding that scope and that they have seen a corresponding increase in service in the rural areas, I think that would help us on this panel to kind of connect those dots. I think that's what Senator Greenville is getting at.
Well put, Mr. Chairman.
Yep.
There's a beautifully illustrated map that's supplied. I can give you a copy later. It's nicely color-coded of the lower 48 states. And the greenest area is the Northwest, more thinly populated. I have a brother who's a heart surgeon in South Dakota. They just passed total nursing practitioner autonomy the other day. The states western in the Northwest seem to be they're more distant. They're thinly populated. Populations are thinner and more sparse. And for that reason, the nurse practitioners are filling that gap and going out in those communities and serving those people. Whether or not, and I'll mention this shortly, whether or not some of the trained doctors, like in Vail and in Colorado, they're gravitating toward hospitals for a better lifestyle, and I'll mention this shortly. But you need somebody to go out into the hinterland and treat those sparsely populated patients. The societal and political pressures in America and the world today are pointing toward healthcare as a fundamental right, and that begs and introduces the next problem already mentioned, and that is cost. But it must be paid by either a capitalist society or a socialist society. The United States continues to explode its national debt as entitlements consume over 60% of all federal spending. In summary, the future of healthcare technology is still bright in this country, but accessibility and cost continue to overwhelm the system until it reaches a breaking point, and nobody quite understands when that breaking point will occur. With this preamble, let me focus on the issue at hand, the enhanced and perhaps even total autonomy of properly trained and credentialed and indemnified nurse practitioners in their unselfish quest to provide for primary health care and thereby help fill the gap left by inadequate numbers of primary care physicians as forecast. Nurse practitioners are available and ready to help fill the gap and thereby make serious impact on accessibility and cost in primary care in America. The arguments against the enhanced or total autonomy of nurse practitioners as they seek to fill these positions are old and stale. The naysayers say that physicians are trained better and longer, know more, are safer for the patient, and more cost-effective. If that were the case, then why are physicians continually subject to malpractice challenges and often respond with expensive defensive medicine? And why is this country going into insurmountable debt with health care delivery, debt to our nation, along with ever-increasing premiums for health insurance, which is the problem we're facing with the ACA now? Meanwhile, the arguments for enhanced and total nurse practitioner autonomy are certainly picking up steam nationwide. Over 30 of our 50 states have gotten beyond this point and granted full autonomy to nurse practitioners as they fill the gap in their particular states. The studies have shown that nurse practitioners in independent practice are well within the parameters of availability, cost, and safety with respect to their physician counterparts. These facts should not be ignored by South Carolina as the wave of nurse practitioner autonomy sweeps across the America, with the intention of providing all too needed accessibility and helping to hold down costs. A lot of this data and material that I'm talking about I treat very superficially, but it's all in your packets and all in that CD with lots of research material on it. Another important point, an ever-increasing number of physicians are seeking solace, improved lifestyle, regular salary, reduced overhead by joining or, shall we say, being bought by larger urban hospitals. The hospital wins by enhancing its primary care population to protect its future turf and referrals. Nothing wrong with that. It's a good business model, but it benefits the hospital. However, the rural areas often get shortchanged. Mobile clinics may help to mitigate the poor degree of accessibility somewhat, but there is a better solution. Nurse practitioners have shown that they would do well to practice in such areas and provide much better accessibility. And with meticulous, one-on-one patient care at the office, not the mobile unit, not the hospital, one-on-one patient care at the office, nurse practitioners can greatly reduce, and this has been shown, with the frequency of ER visitation at the nearby hospital, thus saving declining and thinly stretched healthcare dollars for the country. I digress for a few moments. Noticeably, I frequently emphasize three requirements about nurse practitioners as they gain more autonomy in the workforce: properly trained, properly credentialed, and properly indemnified. That speaks a bundle about providing safety in health care to the American public. Physicians are no less required to fulfill the same three requirements. Training includes formal education, hands-on experience in a sheltered academic environment, and the completion of alphabet soup behind your name. Even at that point, very few new young physicians or nurse practitioners are capable of setting up their own practice, learning office procedures, billing, scheduling, correspondence, developing referral patterns. That's a big one. Most newly trained professionals seek association with a senior partner to learn the ropes. And then after a few years, they're ready to venture out on their own, and training doesn't end there. There is CME credit requirements, new procedures to learn, and new drugs. Being a healthcare provider is a lifelong learning experience. We all agree to that. Credentialing by federal, state agencies, and by local hospital committees is essential to declare to the world that this healthcare provider is who and what he or she says he is, and is ready to perform within the boundaries of his or her education and training, commensurate with ongoing CME credits. Essentially the same for doctors and nurse practitioners. Again, another step to ensure that healthcare provider is safe for the public. And lastly, since humans are not perfect, we have necessary indemnification to cover our mistakes, and we will make mistakes, hopefully very rarely. In any case, in a free market where quality and safety is at the forefront, and where training, credentialing, and necessary indemnification is the foundation, then any further restraint on new business ventures would probably fail and be fought ultimately in the courts. I want to read that again. In any case, in a free market where quality and safety is at the forefront, and where training, credentialing, and necessary indemnification is the foundation, then all further restraint on new business ventures will probably fail and be fought ultimately in the courts. I say that if any healthcare provider is properly trained, properly credentialed by multiple government agencies, and properly indemnified, then they have a legal right to enter the free market and let their handiwork speak for themselves. But there is no substitute for common sense, and most new physicians and nurse practitioners will wisely be mentored by a senior healthcare provider in private practice until the little hatchlings can fly by themselves. It is a rare new doctor or nurse practitioner who can start up a successful practice by themselves without the supervision of a senior mentor. It is important to understand that safe health care is rooted in good old common sense. As a medical doctor and retired cardiac surgeon, I've seen the abilities and professionalism of nurse practitioners, whether primary care or a specialist. I've been well satisfied. As a lawyer, I recognize that in this world we may wish all things to be either black or white, but we as a society must live, adapt, and compromise to the gray hues in between. Interpretation of this, in our national health care system, with obvious lack of total accessibility and ballooning uncontrollable health care costs, not only to the patient but to the nation, costs which compete with our failing infrastructure and national defense, we must assess and channel all our resources, including nurse practitioners, to ensure that our nation will continue to have the world's best, most efficient, and most effective healthcare system in the future. That does not mean lowering standards. When I went to medical school, we had 164 white males. Since that time, the diversity is tremendous. Medicine has not suffered. There's probably more women in med school now than men, and minorities have really claimed a 20-30% stronghold. Likewise, in law school, when I went back in 2001, we had over 50% of the class were women, minorities were well represented, and neither medicine or law has suffered that I can see across the country. A day of reckoning, that does not mean lowering our standards, and we will never do that short of a national emergency or crippling financial debt, which could occur. A day of reckoning will come. We do have a new president who may try to seriously reduce the national debt, but this may neither be certain nor possible. But somehow the consequences, nonetheless, will be felt by the healthcare system in America. Whether nurse practitioners properly trained, properly credentialed, properly insured, that's the three things that you've got to look at, still must, by state law, practice with either collaborative agreements or direct physician supervision, or, on the contrary, whether nurse practitioners may soon, by either evidentiary proof or by legal right, be allowed to practice independently, free of those restraints. There is no question that nurse practitioners can and will fill the void left by physicians in serving the rural and urban areas, uninsured and insured patients, chronic and acutely ill patients in our state, and they have demonstrated that they too will focus on accessibility, cost, and safety. And yes, just perhaps, by maintaining their proven track record of being well liked by their patients, they may help to bring back the much-needed art of medicine which we once had in this country. I rise in support of Senate Bill number 345 in all of its provisions, and continue to press for total autonomy one of these days. I thank you for the opportunity to appear before the subcommittee in support of the enhanced nurse practitioner autonomy. Thank you very much.
Thank you for your testimony, Dr. Owens, very much. Thank you. Anybody else who's traveled over 2 hours? Come on up.
Senator Davis and committee members, I thank you for letting me have a little opportunity to talk to you. I'm Dr. Keith Guest. I'm from Beaufort, South Carolina. I run a geriatric practice, and we have offices that are throughout the state. We have offices in Spartanburg and Greer, Rock Hill, Beaufort, Hampton, Saluda. We take care of people in Barnwell, Blackville, and we take care of people in North Augusta, basically throughout the state. We heavily utilize nurse practitioners, and they're integral in our practice. I'm here to speak in favor of the Senate Bill 345 as written, because it really does improve care to the citizens in the state of South Carolina. It replaces the kind of an antiquated definition of what supervision is, and with a more current, modernized version of supervision. But it doesn't give complete and free autonomy. This isn't like letting the nurse practitioners go out and set up their own individual practice, which now many states do that, however, but this is not that bill.
And you just made a very important point that I'd like to share with my colleagues here. What we're doing essentially is updating a set of laws that were passed years ago.
Correct.
And subsequent to that time, nurse practitioners are trained and qualified and able to provide a range of services that aren't necessarily contemplated by those earlier laws.
The original provisions.
What I see us doing here, at least what I envision our task to be, is to allow nurse practitioners to render the sort of medical care for which they are qualified and have been trained to provide, and to bring our law into conformance with what's actually happening out there in the world. I mean, that's the way. So I'm glad you made that point from the very outset, because we're not talking about throwing everything out. We're talking about modifying a set of laws that are not properly reflective of how nurse practitioners are trained.
And that's one of the things that, although I'm a member of the South Carolina Medical Association, then they sent out an email that said we should speak against it. Their concerns were that we were just letting the nurse practitioners go out and set up individual practices, which is not true. This bill does not provide for that.
Right. Okay. Thank you. I'm sorry to interrupt. Go
That's
ahead.
okay. And that's one of the reasons why I say I support the bill as written, because it is a well thought out, actually, and it doesn't give them complete autonomy. They're still required supervisory roles for physicians, and they still have to have a collaborative practice relationship, but it modernizes it and gets it up to the new training standards for which the nurse practitioners that we employ are well equipped to.
So based on your experience and in working with nurse practitioners, is this particular bill more reflective of what they're able to do and what society should entrust them to do, as opposed to current law?
Absolutely, it is. And it also, but it even adds, I mean, even though you might think that this is going to improve or allow more freedom for nurse practitioners, in many ways it does, there are some parts of the bill that are even more restrictive as far as new graduates are concerned, as far as how many hours of experience that they have to have. So it does, in some ways, is even a little tightens up some things in regards to, for example, new graduates. Okay, so, and I think
in other
that's
words,
a good
with increased scope comes a higher requisite or need for training or for being prepared, because they go hand in hand.
On-the-job experience.
Right. Okay.
And it's also one of the things that it does is modernizes some of the things like mileage constraints. Now it used to be that when say well, they want you to be within a certain number of miles with the nurse practitioner, so that if necessary you could rush over there as the doctor and be there within a certain number of minutes. Okay, but now with the way we have telemedicine being done, and with the cell phones, and they just can Skype me and they can say, look, does this look like a seizure to you? And they can just hold their phone up and I can look at it, or we can do telemedicine, or they can pick a picture of a rash, or they can say, does this arm look dislocated to you? And I mean, the mileage constraint just doesn't make sense anymore. I'm not with telemedicine and the new way things are happening. So the 45 miles essentially assumes that if there's a problem, the physician's going to get in a car and drive out to wherever the nurse practitioner is. That's the old assumption, which is not correct. And what it does do is things like, for example, we have at Beaufort Memorial Hospital, if we get a discharged patient and we want to prevent a readmission rate, which is something that Beaufort Memorial has been grappling with and trying to reduce hospital readmission rates. If I can send a nurse practitioner to Hampton to see that discharged patient from Beaufort Memorial, then they can make sure that the person has doing good transitions in care, that they've gotten all their medicines that they're supposed to get, that they got the hospital bed delivered to the house, and that they have all the equipment that they need to be successful after discharge. Unfortunately, with the way the laws are now, it's too far. I can't send them. They say, well, you're too far away from me, so I can't send you out there with the way the current laws are written. But so we're getting rid of those mileage constraints would allow us to get further into more rural areas, and it makes more sense nowadays with the way that with new communication techniques and things that we have, and it allows us to really do better transitions in care. As also,
Excuse me, sir. Senator from Greenwood.
Yes, quick question. How does this change the collaboration and the supervision by the physician?
Well, one of the things is, if, for example, for the mileage constraints in Greenwood, if they went to Self-Memorial and then they were being discharged over to Saluda, for example, to go to one of the assisted living facilities, well, it would allow the nurse practitioner to practice more than 45 miles away, right? And so it would allow me to be able to supervise them at a greater distance. Now, it doesn't really make sense that they are required to be within 45, because I'm not going to really get in my car and drive over to that assisted living facility anyway. And if the hospital fails to discharge them with the required C2 medications, let's say, for example, the person had a fractured hip and they left the hospital and the hospitalist, for one reason or another, didn't send the prescription for the Percocet for their hip pain after the broken hip, well, the nurse practitioner could write the prescription while they're there. And that's another important thing that this bill allows them to do, to be able to prescribe C2 medications. I never really understood that several years ago they changed the prescribing authority and they allowed physician assistants, who actually have less training than the nurse practitioners do, but they allow them to prescribe C2s, but didn't allow nurse practitioners to do it. That was like, I didn't ever understand that one. Because these people are better trained than physician assistants. They have higher requirements and standards.
Okay.
So,
So clarify for me then, what, if this bill passed as is, what will be the relationship now going forward between a doctor and a nurse practitioner?
well, they still have to have rules as far as supervisory rules and stuff, and so you still have to have a collaborative practice. They can't go out like and according to the way it's written here, like they can in New York State or in some other states, where they can just go out and hang up their shingle and say, I'm a nurse practitioner, you can come see me, and I don't have to report.
Okay, so see, that's what I thought this bill did, the way I first read it, and I've been over here rereading it, and forgive me because I read a lot of bills, being on a lot of committees, so sometimes I scan them. So if this bill passes, they can't just go out and hang up a shingle and start practicing medicine.
No, sir. They can't. They cannot do that. Not with this bill. Not the way it's written. There still has to be some supervisory role.
Okay. So what advantage is it? Like the very first lady we heard speak, and she's concerned that she may not get a doctor to sign that form and become her collaborative doctor. What advantage is it for a doctor to enter into this agreement with them? I mean, I'm trying to figure out ultimately how we get down to this area, this fine end result of serving the rural areas.
Right. Okay. Well, several things. Okay. For example, we are limited in our practice because right now there's limits on how many nurse practitioners per physician in our practice we can have, and it's 3 per doctor. But we could have more than 3 per doctor. And so, for example, in her case, I live in Beaufort and she lives in Johns Island, and she's too far away for me to supervise. Right. But if we got rid of the mileage restriction, and I already have 3, so I couldn't take another one, I could do it. I would be happy to do it for her. Mm-hmm. So she could have her practice, and I travel around a lot by plane, because our practice is all over the state, and it's really easy for me to fly from Beaufort County Airport to Barnwell. It's a 17-minute flight. You know.
Yes. What about the liability concerns she mentioned about how physicians weren't willing to be the supervisor because of the vicarious liability aspects of that?
Well, unfortunately, there's not much that we can do within this bill for liability concerns, as long as the lawyers, there's going to be lawsuits, and so there will be people who are concerned about the liability of having someone out with this little or where they're not very close to, or they can't see them on a daily basis and check in on them. Now that depends on the individual doctor and how familiar you are with that type of practice. In my practice, we are very comfortable with having well-trained, qualified nurse practitioners that are independently functioning in nursing homes and in assisted livings throughout the state. And we practice under, practice policies and guidelines. They have nursing protocols that we use. And so we're very comfortable with that type of stuff. Now, so she just might need to expand who she's asking to help her. And if this was to pass, then she would have that opportunity to, like, for example, contact me and say, I know you live in Beaufort. Can you help me?
Right.
And I would be able to.
And this bill eliminates the 3 limit.
Yes, it eliminates the 3 limit.
So this bill, and from what I gather that you do as a physician, and did you just mention placing someone in nursing homes? Is that what your company sort of does?
Yep. I'm a geriatrician,
Right.
and we provide care in 3 main venues, okay? First of all, we try to keep people in their home as long as possible. If possible, we want people to stay in their home until the day they die, okay? And that means bringing the right sets of services. If it's adult daycare where they have to be, where they can go during the day while their children who are grown children are in that sandwich generation, they have elderly parents.
So you're so right. I understand. I have friends that do what you do as well. So this bill would greatly help you.
Oh, very much.
You could hire more nurse APRNs.
Absolutely. I would definitely, first thing do is I'd hire
right.
more.
And your business could boom if this passes.
Well, what we would do is save the state a whole bunch of money, because as the gentleman who was speaking before me, what's happening now is these people are seeking care in the emergency room. They're frail. They can't really get out to the doctor. We only see people who can't get out of the house. They're more or less homebound. And
Don't
so
take
what
that
they
the
do is
wrong way. I have nothing wrong with your business expanding. I'm a capitalist.
Yeah, no, but what they have to do nowadays, though, is very expensive. This is the most expensive way to take care of a patient. They call an ambulance to come and pick them up, to take them to the emergency room to get a refill on their pain medicine, and to take them back home. And it costs the state $1,000, which if the state Medicaid program was paying me, then that would be a $57 payment to me. And so instead they're spending $2,000, for which the state Medicaid program would pay me $57.
Would they really dispatch an ambulance to somebody's home? just
Absolutely. That's the way they do it.
They want a refill on their prescription?
Yes, sir. Yes, sir. Yes, sir.
Really?
Because they can't find a doctor willing to go to the house, and then they can't find a nurse practitioner. Could be an affordable alternative, but because we're prohibited from hiring more than a certain number, or they're too far away, like the patient lives more than 45 miles away, I'm saying, well, I'm sorry, law doesn't allow me to take care of you over there. I mean, you live in Estill.
That's considered a medical emergency, that you need your prescriptions refilled.
Well, yes, because they are in pain. They say, why are you coming? My pain is too bad, I can't stand it. And you say, well, why are you in pain? Well, I'm out of pain medicine. Because a lot of people, some of these patients are like, our average age of our patients is 87 years old. Okay, that's our average patient age. And they're like, have severe spinal stenosis, and they're in terrible back pain. They're not a candidate. No surgeon's going to touch somebody with COPD and heart disease. And
I'm 52 and my back's killing me.
yeah,
As we speak.
so when you get to be a certain age, the best you can do is palliative care. Yeah. You can help them with the suffering. You're not going to make it go away. But in order to do that, if I had nurse practitioners who could go to the distance and could write the medicine, then we could provide improved care to the seniors in this state for sure, especially in the rural areas.
And you get paid for a lot of this through Medicare, Medicaid, things like that?
Yeah, all our patients are Medicare and Medicaid because of their age. They're 100% Medicare and Medicaid.
Gotcha, okay.
And it also gives them the ability to do a few other things. They can sign the handicap forms, so that right now that only doctors can sign those things. It allows them to sign whether or not they're homebound to get the community long-term care involved in the aid and attendance programs for the VA things like that. It allows them to sign death certificates and to register with Web Death so that they can sign those death certificates See, right now in South Carolina, they can serve as a hospice attending. Okay, that means that the Medicare hospice program will allow a nurse practitioner to serve as a hospice attending. And they take care of the patients until the day they die. But then they can't sign the death certificate because South Carolina law says, oh, you can't fill that out. And so they have to contact me, and then they have to say, well, I had a patient who died, and these are the things that were wrong with them. Would you mind going online and filling out the death certificate? It feels kind of weird. I said, I never even saw the person because they were the attending, and they took care of them according to the hospice benefit. But then I have to go and fill out a form for somebody I never even saw. But that's because the laws haven't caught up with the way medicine's being practiced, and that kind of corrects that issue as well in this bill. Oh, you're welcome.
very much in making the trip. And what I'll do, as fate would have it, the people that were over 2 hours away were all for the bill. So what I want to do is have the next three that speak. In fairness, I want it to be those who have come here to testify against the bill. So, and
Thank you.
what I'll do with, thank you very much, Dr. Guest, for making the trip. Dr. Wilson? Okay. I understand you were here the last time too, so I thank you for your patience and willingness to offer your testimony to us.
Well, I didn't have to travel this far.
Okay.
Good afternoon. I do appreciate the opportunity to be
Yes,
able
sir.
to speak to you. And I want to make this fairly brief. I know we've had a lot of testimony, and I specifically have some things I wanted to say.
Mhm.
First of all, I am Gerald Wilson. I'm a past president of the South Carolina Medical Association. I'm a board member of the Institute of Medicine and Public Health, and I'm on the governor's task force for graduate medical education. I have been a chair of the Medicaid Advisory Committee and the State Health Plan. And I also am the chairman of the executive committee of the Palmetto Medical, Dental, and Pharmaceutical Association, which is a predominantly, historically African-American organization. And I think that all of this gives you sort of an idea of how robust an experience I've had in dealing with issues that we're specifically talking about here. I speak primarily in opposition to S.345, and I do it because I think that with the changing face of healthcare that we're dealing with today, there are two primary things that we need to be concerned about. One is we're talking now about population health, and we're talking about bundled reimbursement, which is what's coming about. This is the new face that's coming about in healthcare. And we should have a system that allows us to deal with that, not on a two-tiered plan for healthcare, because that inherently causes problems when you have two methods for providing healthcare. The AMA's position with regards to healthcare with these changes has been that there should be a healthcare team, which is physician-led. The physician should maintain authority for patient care in any team arrangement, and the team should have collaboration among its members, should have shared goals for healthcare across all settings, and there should be coordinated high-quality healthcare. What we're seeing in this state, and this state is different from all the other states in that we know what works best for us in this state. There are about 21 states that have totally independent advanced nurse practitioner practice, 9 that have some sort of variation of that, and the rest are where South Carolina falls. And the physicians in the South Carolina Medical Association now are beginning to realize that we need what's called a medical home model. And that involves more than just what we used to do, which was treat diseases or monitor conditions such as obesity and smoking and that sort of thing. Now it's about preventing and keeping people in good health. So the physicians in South Carolina realize that, as well as the training programs. Family medicine residencies have been probably the first ones that realize that a team approach to healthcare is best served because it looks at all aspects of patient care and keeping them healthy and keeping them away from more expensive methods of care. Medical schools now are training medical students to work in team practices with them as the leader of the team. So I think what we're looking at is a situation where, rather than making changes by a bill which would significantly alter the way we see the practice of advanced nurse practitioners, we already have a method for which we can monitor and change those things that need to be changed between the Board of Medical Examiners and the Board of Nursing. There is a committee which meets on a monthly basis, and they can do things such as adjust the number of practitioners supervised. They can adjust the radius of where practice is covered, and they can deal with those prescriptive authorities. When it comes to things like signing death certificates, according to the Medical Practice Act, that is, a death certificate has to be signed by a physician. I've spoken with members of the Board of Medical Examiners, and they said they have been quite willing to work with and have done so with the nursing board on what changes need to be made without having to put in effect any new bill that would be passed. Therefore, I think that it would be in our best interest to allow them to continue to work as they have been doing over the past several months and make those changes that are deemed necessary as there have been advances in medical care.
Dr. Wilson, can I ask you this? Is it possible for our committee to receive copies of areas of agreement or areas of modification or that have been discussed and agreed upon by those boards? Could you get that to us?
I will do my best and see what information I can get.
I'd be very interested in seeing that and educating myself as to what work has already been done to address some of these areas. That'd be very helpful to me.
All right.
Thank you, sir.
And in closing, I just wanted to mention that we talked about the need for coverage in rural areas. There's no question about that whatsoever. The models that we're looking at now are those such as the federally qualified rural health care systems, which are comprehensive health care systems that have not only physicians and nurse practitioners and nurses, diabetes educators, dietitians, they have dentists, they have podiatrists. That's providing full quality service for those areas, and they're providing it in rural areas. When we look at, and I have a report here from the South Carolina Rural Health Report, which states that when we're talking about rural health care, there are 6 times as many physician's assistants in urban South Carolina than in rural South Carolina, and 9 times as many physician's assistants in urban South Carolina than rural. When it comes to nurse practitioners, there are 4 times as many nurse practitioners in urban South Carolina than in rural areas, and there are 6 times as many nurse practitioners in urban areas than in very rural areas. So the question about providing services in rural areas is not going to be solved by nurse practitioners getting more independent practice, because nobody can survive in a rural area just by going and hanging a shingle there. It has to be done in some comprehensive method where there is the support of multiple facets of the healthcare community, and that's best done by a physician-led healthcare team. Thank you.
Yes, Dr. Wilson. What about what Dr. Guest just said, that if he had the ability to hire more nurse practitioners or supervise more nurse practitioners and have them go out further radius than 45 miles, that would in fact allow him to provide service into those rural areas?
That can be done if it's requested by that committee between the Board of Nursing and the Board of Medical Examiners now without changing the law.
So you petition for an exception and you get the modification.
It's not it can be, those parameters can be changed. According to my talk with the president of the Board of Medical Examiners, he said they get requests from that committee on a monthly basis, and they're willing to work with them on being able to accomplish those things they feel are reasonable.
Okay. Thank you, Dr. Wilson. Senator Greenville.
If maybe have a show of hands or a grin on the face or what, some indication from the audience out there that of nurse practitioners, and I assume you all are the lovely looking folks in the white coats that are sprinkled around there, and maybe some others may not have on white coats. We often offer incentives to different groups for different things. Like, we could offer a $10,000 signing bonus to a school teacher who's willing to go out in the middle of Bamberg County and teach school. What if you were given the ability to be cut loose and free within the agreement that you will move out into these rural areas and start working out there? How do y'all feel about something like that? Y'all would all go. Y'all were all willing to go out and move to the areas if this.
If I may.
But now the rest of you wouldn't get it. Just the ones that are willing to go.
If I may.
Y'all were all good with that.
If I may, the governor.
If
I may, the governor's task force on graduate medical education is looking at just those sorts of remedies for providing primary care and general surgeons in rural communities. They've looked and we have found that in order to attract and get those practitioners in those areas, it's best to get someone who has grown up in a rural area, who's educated in a medical school or osteopathic school here, who does their residency here, and they're inclined to stay in rural areas. The problem we run into with that is the educational system in rural areas usually doesn't provide the kind of background necessary for them to start. So the Graduate Medical Education Task Force is looking at being able to resolve those issues because we have been noting that that's the areas that need to be addressed. And also, there are areas in urban areas where there are deficits in healthcare. There are pockets in urban areas where they have federal rural health clinics that are lookalikes because there is a dearth of medical care in certain areas in urban areas.
You take the time, Dr. Wilson, to testify to us today. Thank you very much. The next, speaking in opposition, because in fairness, we need to do that, Dr. March Seabrook. Dr. Seabrook. Evening, sir. Appreciate your patience.
It is my pleasure to be here, Mr. Chairman, and thank you very much. My name is March Seabrook. I am the founder and past president of the South Carolina Gastroenterology Association. I'm a past chief of staff at Lexington Medical Center, and I currently serve on the South Carolina Medical Association Board of Trustees. I am a gastroenterologist, and today is March 1st. March, the month, is National Colorectal Cancer Awareness Month, and I now know Senator Corbin's age, and I hope Senator Corbin has had a colonoscopy by now.
I will tell the senator from Greenville that when I turned 50, I had a colonoscopy. I went to Charleston and had to drink that horrible fluid for 3 days beforehand in order for it to be an effective test, and it all checked out well. So.
I am confident that you are as good-looking on the inside as you are on the outside, okay? So, and I want to give South Carolina a pat on the back. We are making noise in the country regarding colon cancer screening, colon cancer prevention. The South Carolina Gastroenterology Association, the Center for Colon Cancer Research at USC, Blue Cross Blue Shield, along with you, the legislature, have made an impact in our state on some of the things that we're doing, and we've been nationally recognized for that. So let me say thank you, and for that I'm grateful. There is a program now that almost half the gastroenterologists in the state are participating in that waive professional fees to screen people through the free medical clinics in the state, all around the state. So I'm proud to be a supporter and a participant in that effort. But I am here to give testimony on Senate Bill 345. Let me tell you, let me start off by saying that we work with a number of nurse practitioners in our office. We employ several of them. And I'm supportive of several items in this bill. In fact, there was a House bill last year that put forward expanding the prescription authority for narcotics. So we tried to do that last year. There was also an effort to increase the radius and the number of nurse practitioners that were supervised. So we made efforts trying to go in that direction. And I'm glad to see some of these gaps coming forward that I think are in this bill that could be filled by the non-provincial.
Let me interrupt you for a moment just to supplement what you're saying and also to advise the members of the committee as to what I hope to do here after everybody has a chance to be heard. Rather than trying to move a bill out to full committee, I'd like there to be discussion among the stakeholders to at least have that conversation after having been educated like this and then finding out whether or not there is something that we can consider on a collaborative basis. But just to let you know that would be my intent if you're in agreement with that. But sorry, Dr. Seabrook, but what you just said reminded me to make that observation to the other members of the panel. Thank you.
I would love to think that this bill is about handicap placards and homeschool children. It is more about independent practice. Dr. Guest, I was surprised. He did say that it was more that there was supervision in this, but that was my understanding was supervision was going to lead that. So I'm glad to hear that. I'm not confident that this bill is supported by all the nurses, and I don't think it's about power or money. Maybe to some it is. I don't think it is necessarily to the physicians. To me, it's about education and training and the ultimate responsibility to the patient. Let me give you my frame of reference. I grew up in Anderson, went to Wofford College, came here to the University of South Carolina, School of Medicine for 4 years, then went through 5 more years of residency and fellowship training. I then joined consultants in gastroenterology. I've been in practice now for over a quarter of a century. We have offices in Richland and Lexington County, and we have endoscopy centers in both places. We are independent. We are not employed by any hospital or hospital system. We do procedures and see patients in our office and in the hospital, and we are the primary inpatient service for both Lexington and Providence hospitals downtown. CRNAs are incredibly useful in our practice. We have 6 CRNAs nurse practitioners in our practice, and we also have a number of CRNAs in our endoscopy center. So we deal with both 2 of the 4 sets of APRNs. In the office, my partner and myself share a nurse practitioner who sees maybe 16 patients a day. They are our follow-ups and our work-ins, and we share the cost of her, and she is talking to me every day about at least 2 or 3 of the 8 patients that may be mine. So she is supervised all the time. We have 2 nurse practitioners that are in the hospital. They see consults while we're doing procedures from the patients from the day before, and we talk about patients. They see them, get the information together, and then formulate an initial plan. We then go back behind them and see every patient personally to expand on that plan and give more orders. One of my patients, or one of my partners, has a nurse practitioner that works just for him. He makes rounds, weekends, office, hospital. So we use them in a variety of settings, but they are totally supervised. The other thing is with the CRNAs, if you're familiar with that, they're supervised by physicians every minute while they're sedating a patient during a procedure. So it's total supervision. I know a little bit about what's going on at Lexington Medical Center, too.
It reminded me of something else I wanted to ask. Is it true that in certain instances, nurse practitioners need that greater degree of supervision, and in other instances, they don't, right? I mean, so is there a continuum or a scale where depending upon the service you provide, you may or may not need that physician supervision?
Absolutely. In terms of what they're dealing with, in terms of complexity, having someone coming back from, who say has had an esophageal dilatation for swallowing problems, that's not somebody I need to necessarily talk to her about. I just want to make sure the patient is doing well. Yes, I mean, as with experience, and that does grow, that they do have more latitude, at least in terms of what they may communicate with us.
Does the current law allow nurse practitioners to provide that sort of health care without that supervision?
Not currently. I mean, the word is supervision currently. And the other thing is that when I read this law, and I was a little bit, maybe I missed part of it. I don't remember it saying anything about criteria about new nurse practitioners or their degree of experience. And maybe I'm sorry, I couldn't tell what section that was in. I know that was mentioned earlier. They didn't separate out family nurse practitioners. They didn't separate out the number of years of experience, or if they did, I missed it in the bill, so for that I apologize. A little bit about hospital APRNs, and I can only speak from experience of Lexington Medical Center. Lexington employs 550 physicians. They have 550 physicians on staff. They employ 60% of those. They have over 150 APRNs and another 25 physician's assistants that they employ. They're all supervised. They're all supervised in the office or in the hospital setting. And I want to tell you, listening to some of this, the strategy that at least at Lexington and Greenville, who has an aggressive hospital system, Lexington has put satellite offices in each of the corners of its county. And so they have physicians and nurse practitioners there that can service those rural areas. I listened about Johns Island, something like MUSC or somebody, they should have some program that allows them or expand their reach, because that's in which I think would be exactly where some of South Carolina should go in terms of trying to hit some of these rural areas. Put a focus on the hospital system because they're the ones that are generally employing the physicians. So I know the hubbub on this bill is about the word supervision, the word collaboration, or ultimately independent practice of nurses, or specifically nurse practitioners. And there are emotional anecdotes about this. They need to be addressed, whether they're financial or poorly served areas. And I totally agree with that. And I am in favor. And I speak for myself. That we are interested in looking at the radius and looking at the number of nurse practitioners that are being supervised. I think these are areas also that the large healthcare facilities can put their tentacles into in terms of supplying care. if there are nurses, if the nurse practitioners or physicians that aren't following current protocols, I think that needs to be addressed. I'm not sure you have to change a law, but I think they need to be addressed. And there are lots of arguments about the difference in education and training. Medical school's hard. Training is hard. Training is long. Training is rigorous. I understand that it'd be nice to kind of have a shortcut to be independent, to give independent care. I understand that. The arguments of lawyers and paralegals or teachers' aides, pharmacy techs, they're all out there. And I know there are other states that have done certain things. South Carolina is probably not known for doing what other states do necessarily. And I know the VA's done some things. And quite frankly, at least today, I'm not sure we're looking to the VA to model our care, at least today. I want to conclude by saying that nurse practitioners are a critical part of the healthcare team. And when physicians graduate from medical school, they take the Hippocratic Oath. When nurses graduate from nursing school, they take the Florence Nightingale Pledge. If this bill passes, as I perceive it's written, are the nurses going to come to the State House to take the Hippocratic Oath? I don't know. Is this about? I think, to me, this is about education and training, and it's not about legislation and lobbying. So I'll leave you with that. Anybody can I take this with me, or you want me to leave it?
I'm good for another. How often do I have to have those? I mean,
all right, so 3 sentences. If you're normal, no polyps, an excellent examination by somebody who does it all the time, and there's no family history of colon cancer, you can wait up to 10 years.
All right, so I got 4 more years. Okay.
If you have family history of colon cancer and it's normal, 5 years. If you have 1 or 2 small polyps, 5 years. If you have 3 or more, what we call precancerous polyps, 3 years.
One last question. How much faith do you put in that Cologuard test?
All right, full disclosure. I make my living looking into people's colons, okay? I say that up front. Cologuard is a colon cancer detection test. It detects blood is one of the things it does, but so do hemocults. But colonoscopy is a colon cancer prevention test. So taking out polyps prevents cancer. And so the Cologuard is designed to, quote, detect cancer. Cologuard, I called them up. You know how much it costs? $649 for a stool test. Yeah, colonoscopy is not cheap, but and you do the Cologuard every 3 years is the recommendation.
Well, I just, I knew what went down to Cologuard and this and colonoscopy and this and I know which way I'm leaning.
Well, look, no, I get it. I'm biased. I'm biased about clearly the single best test is a colonoscopy. If from colon cancer screening, the best screening test is the one that gets done. Okay.
Thank you, sir. Daniel Young. Mr. Young? Up, sir. Appreciate your patience and your willingness to share your thoughts with us.
Thank you. My name is Daniel Young, and I'm a fourth-year medical student at MUSC, and I'm speaking out in opposition to this bill. Senate committee members, Mr. Chairman, I thank you for your time. I come before you today as a South Carolinian, as a paramedic, as a future physician, but most importantly as a nurse. During my nursing education, I had the privilege to be educated by many APRNs, Professor Burgess included. I recognize they're excellent clinicians that are willing to serve in the rural, indigent, and underinsured areas of South Carolina. However, I do not recognize them as having an education that is equal to my own. According to the Council on Physician and Nurse Supply, cited by the American Association of the Colleges of Nursing, and I quote, "The growing body of research supports the relationship between the level of education and both the quality and safety of patient care." The AACN goes on to assert their position, education has a significant impact on the knowledge and competencies of the nurse clinician as it does for all healthcare providers. I have undertaken 4 years of undergraduate nursing education and 4 years of formal medical education. I still have 4 years of residency training and 2 years of fellowship training ahead of me. At the conclusion of my residency, I will not consider the care that I provide patients to be simply equivalent to that of an advanced practice nurse. From my point of view, which incorporates both the nursing and medical perspectives, physicians are educationally and clinically superior to advanced practice nurses. I was born and raised in South Carolina. I am the product of public education here. I attended the University of South Carolina, where I earned a Bachelor's of Science in Nursing, after which I worked in the surgical trauma ICU at the Medical University for 5.5 years. This ICU is often viewed as one of the highest acuity ICUs in this state and presented me with challenges that I had never before faced. In order to provide excellent care for my patients, I had to expand my knowledge base outside of nursing by studying independently. By the end of these 5 years, I had risen to be a charge nurse and was viewed as a clinical expert in my field. I was responsible for 17 ICU beds and 3 trauma resuscitation bays. While I was excellent in my role, in the most critical of these situations, I often found myself asking, why? Why do we do the things that we do? So after the years of being a bedside nurse, I made the decision for myself and my future patients to go back to medical school. Nearly everyone told me that my experience as an ICU nurse and a paramedic would make medical school a breeze. When I began classes in August of 2013, I quickly found that they were wrong. The sum of my knowledge gained through many years of clinical experience in an ambulance, emergency room, and ICU paled in comparison to the breadth and depth of information for which I was responsible during the first 2 years of medical school. It was at that point, only 1/5 of the way through my devoted medical education, that I realized the true danger that is potentially presented when mid-level providers, such as APRNs and PAs, practice independently. The realization that you don't know what you don't know. I had often assumed during my career in the ICU that physicians were making poor decisions. Now I realize it is the physician who is responsible for integrating an enormous volume of information about a patient to truly provide quality, holistic care. Decisions that did not make sense to me as a nurse now are revealed as the most reasonable course of action. Knowledge may be power, but more importantly, it is responsibility. One of these responsibilities is the stewardship of controlled substances. We are confronted on a daily basis with the consequences and realities of an opioid crisis that has gripped our nation, a crisis which at its root is the result of overaccess and overprescription of narcotic medication. According to the CDC, 91 Americans die every single day from an opioid overdose. A PBS News article this week showed South Carolina currently ranks 11th in the nation for the most opioid prescribed per capita. There are more opioid prescriptions for South Carolinians than there are South Carolinians. Why would we as a society attempt to combat the epidemic by further increasing access to these dangerous drugs? These protective mechanisms to control Schedule II narcotics are in place for a reason. As a nursing student, I was taught that nurses do not diagnose and do not treat medical conditions. Some of those individuals behind me are arguing in favor that this bill receive 2 years of clinical training following their nursing degrees. The online Doctorate of Nursing Practice program at MUSC, which was previously ranked #1 in the country, requires 1,040 clinical practice hours before graduation. I have received 3,500 clinical hours in the past 2 years of medical school and will receive another 15,000 in the next 4 years of residency. That does not include my 2 years of fellowship. Should this bill pass, a nurse practitioner with 1,040 hours of clinical experience will receive independent practice-like privileges that I will have earned only through 20,000 hours of clinical experience, passing 3 National Medical Board exams, followed by specialty board exams. While those of us in this room can easily recognize the difference, the layperson scheduled for an appointment at a community clinic will not be aware of the experiential divide that exists between physicians and nurse practitioners. Instead, they will see a clinician in a white coat who calls himself or herself a doctor without understanding the breadth of care or lack thereof that each provides. So I will ask you, senators, if it was your family, your mother, your spouse, your sons, or your daughters, who is it that you would like to be providing that care? Thank you.
Appreciate your testimony, and I guess the response to the question that you just asked would depend upon the level of care that I was seeking.
Absolutely.
And it would depend upon whether or not I lived in an area where I had access to a physician. And certainly I am not making the argument that there is a equivalence between the training that nurses or nurse practitioners get and medical doctors get. But what I am saying is that we have a healthcare access problem in South Carolina. and there simply aren't enough of the qualified physicians that you will one day become to go around, from what I'm hearing. And this is about, to me, not the equivalency between registered or nurse practitioners and physicians, but allowing nurse practitioners the latitude to provide the care, a limited range of care for which they are trained, okay? So I think the answer to my question, or your question, would be depending upon the level of care that I needed at a particular time. But in any way, I appreciate your testimony. I appreciate all the work you're putting into this, and I appreciate you taking the time to share your thoughts with us. And I would ask my colleagues if they have any questions. And then, thank you, sir, very much. Good luck to you. Okay, let's do this. We've gone ahead and done the parity thing with the 3 for and the 3 against. I want to bring up 2 at a time. I'm going to bring 2 up in support, Dale Barwick and Carolyn Daniels, and then I'm going to bring up 2 in opposition, Hugh Durrance and Ralph Riley. Okay, so we'll go first to Dale Barwick and Carolyn Daniels. So you'll both come up to the table there. Okay, it may be that, is Carolyn Daniels still here? Okay, how about Scotty Shelley? All right, we'll get Scotty to come up here, and Mr. Shelley, excuse me. Okay. All right, Mr. Shelley.
Okay.
Thank you for your patience and willingness to share your thoughts with us.
Oh, thank you. My name is Scotty Shelley, and I support Senate Bill 345. I support Bill 345 that will remove the barriers and enhance the capabilities of the nurse practitioners to increase access to care, especially in primary care. As you've heard multiple times here today, there is a shortage of primary care positions in South Carolina. Just last year, or this year, we have fell to 42nd in the nation, down 2 positions from just 2 years ago. The last 2 years, South Carolina spent over $140 million in ER visits for issues that could have been treated by nurse practitioners in the clinic. 65% of ER visits are non-emergent, spending over an average of $1,200 for simple things like coughs, colds, urinary tract infections, bronchitis, and yes, as we've heard, medication refills. The average nurse practitioner visit is $60. The top 15 diagnoses that were seen in the ER visits could have all been seen by nurse practitioners in an outpatient clinic. What you've heard here today is a lot from the opposition about supervision and physician-led teams. One member of the South Carolina Medical Association said, and I quote, "Someone needs to monitor and establish care protocol and assures patient safety, and they are getting the best quality of care." Well, there is nobody in this room that disagrees with that statement, that they should be getting the best quality of care, and there should be some kind of measure to make sure. But let me give you a couple examples of physician-led teams and supervisions that truly is being practiced today. I work in several different positions. I work in a hospital, I work in a clinic, and I also do geriatric practice. And I go to Fairfield County, and I go all the way down to Aiken, Blackville, and Williston counties. I see at least 6 different facilities that I go to in geriatric practice. The doctor comes there once a week to one of them. He comes there once every 2 weeks to the other. I see the patient, do all the diagnostic tests, order medications, anything they need. If I need a narcotic, I have to then call the doctor, say, "Hey, Ms. Jones is out of her hydrocodone. This is what I think. Her pain's controlled." Give him an assessment of it. He sends a script. The script can take up to 2 days to get there between fax, the nurse not getting it, the pharmacy not getting it. So the patient can be out of medicine for up to at least 2 days. Sometimes it's been more, but minimum 2 days. Whereas if I had the authority, as I did when I worked in North Carolina, I could just write the script myself, say, "Here you go," the lady gets her pain medicine. On top of that, he comes, "We need diabetic shoes. We need a hospital bed. We need hospital equipment." I can't write for that. Now, I can sign all the forms, and I can fill out everything that's needed, but the doctor actually has to fill it out. He'll do it. He don't even see the patient, but it's done by me, and it's done by other providers that are out there. They just literally sign the paperwork. So we're already doing this out there in a clinic. On top of that, You're talking about hospice. There's a lot of patients out there that need hospice care. By law, I can't order hospice. I can't provide palliative care. So if your mom is out there and she needs more pain medicine, it may be a little bit of a delay before I can get it to her. There's a hospice house here in Columbia that I see and I go to at least 3 times a week. If they need more medication, I have to call the doctor to make sure he can get the medication. Now, here it's a little sooner because he's actually in Columbia. But when you're 45 miles away in a rural area, that doctor is by phone only. So any medicine's being done is by fax. So that also delays care. And when you're in hospice care and palliative care, the last thing a family wants is to hear, I'm sorry your mom's in pain, but we don't have a doctor. I'm sorry your mom's in pain, but I can't get you that pain medicine because of the laws in South Carolina. However, if you were up in Charlotte, I could make her more comfortable. Another clinical setting I do is primary care clinics. And when I'm in a primary care clinic, I see 30 patients a day. The doctor sees 20 or 25 in another office. Never do we intertwine. If I need a placard for a handicap or I need a narcotic, I walk down the hallway, I tell his medical assistant who has a 6-month certificate, hey, I need a narcotic for Miss Jones and this is what I need. She gets it from him. In between his visits, she walks it down there to my office and Miss Jones gets her medication. He doesn't see her. He doesn't assess her pain level. I do. The person that needs the hospital placard, or excuse me, a debility placard, I fill out all the paperwork. He signs it. This goes on in a lot of practices out there. The doctors aren't even seeing the patients that we're doing the work on. So the things we're asking for, we're already doing. But they think it's so beneath them in the real world, and I agree. A doctor and all his knowledge should not be filling out paperwork for that, and I fully agree. But then don't sit here and tell them, oh, we need such supervision because we don't know that you can fill out the paperwork right, or know if somebody don't have a leg or can't walk 50 feet because they have heart failure and need a placard. One of the other clinics, oh, I'm not done. One of the other clinics I work with 2 nurse practitioners that have their own clinic. They pay a supervising physician $2,000 and $3,000 a month to fill out the piece of paper that the young lady talked about earlier to be their supervising physician. Every 6 months, they'll come in and generally do 10% of the charts. They'll review charts. They have yet to speak to them any month on any questions. They've never came to the office for supervision, but yet they spend the money of $2,000 and $3,000 every month to do so. Now, I'm going to take a little page out of the president's book. I know all the best people. I know all the best doctors. I can get them on my phone. But guess what? They're not costing me $2,000 to ask them a question. It's a simple professional consult. Or, hey, Dr. Jones, I got a question about cardiology. I got a question about this. But they're not charging me $2,000 to do it. I just wanted to say something quickly. The 2 physicians that came up here and spoke, Dr. Wilson, Dr. Seabrook, both of them spoke in opposition. They are not primary care physicians. In fact, I've not heard, I think I will from Dr. Riley, but as of yet, we've not heard from an actual primary care physician. When you work a specialty, this bill is not about a specialty. It is totally different. When you're a supervised area like gastroenterology, which Dr. Seabrook is, when you're a surgeon like Dr. Wilson, or you're a cardiologist, if you're a practitioner, they're the ones that take those extra training, the extra years of training and internships. And when you work for them, it is a more direct relationship. It is a more supervisory role. And even the ones that I know that do those roles, they really work a lot of autonomously doing cardiac or some of the other stuff. But they are more supervised because this bill is not about going out there. There is nowhere that if this bill approved, that I'm going to go out and start cutting off people's legs and going, hey, if you need the other one done, I can do that for half price and cut Dr. Wilson out of work. That's not the way this is. I'm not doing colonoscopies. There is no practitioner. That is a specialty. Those providers, those PAs, those nurse practitioners are totally different. They do work in a more supervisory position, even though they have a lot of autonomous range, but this is about primary care. The young med student that testified about his bedside nursing experience, it was not advanced nurse practitionership. It was bedside nursing and what he's learned in medical school. He testified against a lot of things, but he did not testify that he was going to go to family practice or rural area, which again is what this bill is about, getting providers out there to take care of these patients. The 45-mile rule we've heard is outdated. I have 2 kids, both of them teenagers. I supervise them at the house, make sure they eat right, what they're watching on TV, and if I can, what are you doing on your computer? But make no mistake, when they go downtown, they're unsupervised, and that's 7 miles. When I'm out practicing 45 miles away, there's no supervision. Just because a doctor says, hey, you can call me with a question, that is not supervision. Again, I can always call a doctor, I can call a nurse practitioner, anybody for a question, but you're not supervising anybody from 45 miles away. And again, when that rule was set, it was made to, hey, you're in the same building, you're in the same office, not for 45 miles away, but yet we're practicing as such. I could give you a lot more examples of supervision or MD-led teams or the lack of, but the point I wanted to make is the word supervision is being misrepresented here during these proceedings and in our scope of practice. So let's call it what it is, and that's truly collaboration, not supervision, so change it. Studies also show that nurse practitioners provide high-quality, cost-effective care, and in some cases provide better access to seeing patients sooner for acute issues. The Federal Trade Commission has made 3 statements and observations about these issues. Number 1, they say that MD supervision of nurse practitioners is in direct conflict with the educational system which prepares the nurse practitioners. Also, the physicians are now promoting physician's assistants, which you've heard already, while hindering the nurse practitioner practice. Again, this is in direct conflict according to the Federal Trade Commission. The Federal Trade Commission has also recently encouraged state legislatures to permit advanced practice registered nurses to practice without unnecessary supervision. They also report studies now show no difference in outcomes. Hear me, no difference in the outcomes in the states where they can practice independently compared to physician practice. 30 states already allow independent practice. This isn't a new request that we're here today, nor is it a new concept. The VA just announced independent practice in all 50 states for the VA facilities and veterans. The nurse practitioner should be allowed to provide health care.
About that,
Sure.
'cause about the VA. Talk to me a little bit about what the Veterans Administration did.
So the Veterans Administration, after, and you know, anybody that works for the government knows there are many studies and a lot of looking at different sources, have now said if you work for the Veterans Association, that is not a supervising physician. So while you work for them, you may directly report somebody in your chain of command, or like if I work primary care, I would be answering to somebody who was in the chain, but you wouldn't have a direct supervision. I could write orders as such. There would be no direct supervision. But they realize that supervision isn't what's going on out there. We're already in team-led medicine. Yep, that's a new policy of this year. Yes, January. No, yes, sir. Nurse practitioners should be allowed to provide health care that they are trained to provide. It is time for South Carolina legislature to remove barriers and allow access by doing the following. First, remove MD supervision and allow true collaboration. Remove the 45-mile radius. Allow us to do the things that we're doing already. Order hospice, physical therapy, order free medical samples in clinics, sign handicap placards, sign home health, death certificates, and medical equipment. This is already, as I showed you, shows many days of delays in care and sometimes weeks when it comes to equipment and other issues.
That list you just read off, when you're done, could you give us a written copy of the list of the services that you?
I can, but it's in the bill. There's a list of the things.
So you're reading from the bill, not
No,
just.
that was
okay,
a
okay,
sub-sort.
Okay.
No, but it's in the bill, but I send you any information you want. These are the things that we're already doing that I talked about that the doctor signed off for, but we're already seeing, evaluating, and ultimately treating for. Allow scriptive authority for Schedule IIs. Again, other states were allowed to write. I was able to write for them in North Carolina. South Carolina, I cannot. The physician's assistants can. So again, this goes back under when they talk about wanting to be over us. The doctors are over the physician's assistants. You have nursing over nurse practitioners because that's where we worked from. They're allowing PAs to do more and write scripts, whereas we can't, which again is hindering our trade. So to even try to move us under, because one of the board members that said they think that we are to be under the medical board, well, that we would be like a stepchild. I mean, if you're already letting them do this, you're already hindering us. It's kind of like, how can you be over both? But they already allow the physician's assistants to do so, which does hinder our trade and also the care of the patients. There has been plenty of research and studies obtained in 30 states and the VA systems that support and allow independent practice and collaborative practice. We ask for South Carolina to now step up and do the same and give South Carolinians the access and the same good care that they deserve. In closing, I urge you to support Senate Bill 345 and remove barriers and allow access to care. Thank you.
Thank you, Mr. Shelley. Any questions for Mr. Shelley? If not, we'll move on to Ms. Barwick.
I'm Dale Barwick, and I am way out of my comfort zone. My husband is Tony Barwick. I think some of y'all might have met him when he ran for Senate in 2012. I'm from Sumter. I am an adult nurse practitioner. My husband is a public speaker. I'm not. So I told him I was going to come up here, and I'm going to do what I'm good at, which is talk and tell stories. So I'm going to talk to you about what has happened in my life as a nurse practitioner. I have been a nurse practitioner since 1990. I was the first nurse practitioner in Kershaw County. When I got out of school, I got my master's at USC. I got my undergraduate degree at Clemson. When I got out of graduate school, I went to work for a group of internists over in Camden. And I will be the first one to tell you, I was not ready to practice independently when I got out of school. I knew a lot. And the people who say you don't know what you don't know, I don't like that statement, because when you don't know what you don't know, it doesn't even make any sense. So I think I have been very careful throughout my career on anything that I'm not sure of. I have asked somebody who has more education and experience in that area. So I would say probably after I had worked for a year or two full-time with that group of physicians, I did not have to ask them very many questions anymore. I will also say that those physicians and all the physicians that I've subsequently worked with, they collaborate with each other. They ask questions of each other. They go grab each other in the hall and say, hey, come look at this. I mean, that's what we do. We ask our colleagues for second opinions on things that we might be unsure about. So after I left Camden, I then went to Sumter. I worked for a group of family practice docs for 7 years. After I left there, I went to work for a geriatrician for 5 years. So I have, in the last year, getting ready to move to a different district, different congressional district. In the past couple of years, I have spoken with Bobby Ridgway, and I've spoken with Merle Smith and Thomas McElveen and Kevin Johnson about some of these issues. Senator McElveen and Representative Smith are in the district where I live. The other two are in the district where I'm now working. Now, I would like to refute some of this, I guess, language that some of the people that are against Bill 345 have said, which is the independence thing. I am independent. I have worked independently since 1992 for the most part. In that, I don't have anybody looking at the charts that I sign off on. I don't have anybody following in behind me, seeing what I do, asking me what I do. I've been making rounds in nursing homes for many years. The doctors that I work with and for have not supervised me in any way. I mean, I go in, I make my diagnosis, I prescribe whatever treatment is needed. In June of last year, I decided that since we were getting ready to move to the lake, to the district where I'm currently working, since we were getting ready to move over there, I wanted to work over there. So I went to the little town of Somerton, which is near Lake Marion, and there at one point were 3 clinics over there. So I thought I'll find a job in one of those. All 3 of them were closed. One of them had been a federally qualified clinic. It closed. One of them had been a clinic owned by the hospital in Manning. It had closed. And another one had been a clinic owned by private physician practice, and it had closed. So I went into the local pharmacy to ask what had happened, and various things had happened, mostly mismanagement by the people who had managed those practices. But basically, nobody in Somerton had had local primary care in over 7 years. So the physician, not the physician, the pharmacist that I talked to over there said that he owned a building, and that if I was interested in providing care over there, he would give me the building for free. So long story short, this was in June. It took me until January to find a physician who would agree to do that, who would agree to be my backup physician. I do not call them supervising physicians because they do not supervise me, and they haven't since 1990, since I got out of school. So the barriers that I have found in trying to set this up, one was trying to find a physician who would agree to sign on the dotted line, like Ms. Bayer said, because I wasn't going to ask somebody who didn't know me. I mean, why would a physician who didn't know me agree to be my supervising physician? I mean, I wouldn't agree to that liability of supervising somebody I didn't know. So I went around asking doctors that I'd worked with. All of them already had 3 nurse practitioners. I looked at the mileage between Camden and Somerton. It was more than 45 miles. I went to Manning and asked doctors in Manning. Most of them have been bought out by McLeod, which bought out the Clarendon Hospital over there. The powers that be would not let them be my supervising physician. I even asked Bobby Ridgway if he would do it, and he couldn't because the hospital told him that he couldn't. So that was it was very difficult to find somebody who could do it. Andy Reynolds is in Sumter. He is a physician, and he has graciously agreed to be my supervising physician, and he isn't charging me anything right now. I took out a $25,000 line of credit so that I could start this business up myself. So far, I am still $25,000 in the hole. Hopefully, once my insurance payments catch up, then I will get out of the hole, and my husband would really like that. But I wanted to tell you a little bit about the patients that I saw when I got there who have had no care in 7 years. They are patients who ride their bicycle to see me. They walk to see me. They beg, borrow, and plead with their neighbors or their preacher to bring them to the office. They have diabetes. They have high blood pressure. They have high cholesterol. They haven't been taking their medicine in years. I mean, these are diabetics whose A1C is 15. It's just unheard of. So these people are coming out of the woodwork. I started in January, mostly Medicare, mostly Medicaid, a good many uninsured. So I'm allowing them to private pay. I'm charging them $50 a visit. I can diagnose, treat. I can send them for labs, the ones that I'm not doing in the office. I can completely take care of what they need. If there's something that they need that I can't take care of, I'm either referring them to a doctor who's a specialist in whatever area it may be. I've sent some people to cardiology. I've sent some people over to be admitted to the hospital by the hospitalist because they were that sick. I'm concerned because a lot of these patients did go to the emergency room for their medications prior to me coming there, if they could get there, and that is expensive. And I'm also concerned because a lot of these patients have had strokes, they've had heart attacks, and at this point, you know, if we're not preventing some of these things, if we're not treating the diabetes and the high blood pressure and the heart disease, then they're going to have heart attacks and strokes. Then you're stuck with insuring a patient who has who's disabled, or maybe even have to go in the nursing home to be taken care of. So those are just some of the concerns that I've seen just in my one little neck of the woods. I wanted to also refute a few things that were said by the medical student. And one thing that he said is that the opioid problem in our state, I just wanted to point out that the people who are prescribing opioids in our state are the doctors. So if it's opioid problem in the state, it isn't because of the nurse practitioners, because we aren't prescribing Schedule 2s, we're prescribing 3s, 4s, and 5s. I think it's very important that we would get that ability to prescribe Schedule 2s. Right now, I have some people that are in chronic pain. I have a patient who has metastatic breast cancer. I'm having to leave my office to drive to Sumter to get Dr. Reynolds to sign a prescription for her Norco and he's never even seen her. I mean, he doesn't know her. He's just taken my word for it that this is what she needs. He's having to sign the handicap placards for the patient who has a leg amputated he's never seen. I mean, these are just barriers to care for these poor people that would not be taken care of if I hadn't done this. I wanted to refute something that I think his name was Dr. Kerr last week, said that we should be allowed to take care of the low-hanging fruit. And I took offense at that, first of all, because of my training and my education, I can take care of more than just low-hanging fruit. And the other thing is my patients are not low-hanging fruit. These are poor, uneducated, and underserved people in our state, and I think they deserve health care. The doctors are not giving it to them. The big hospital systems that one of these doctors mentioned, they're pulling out. I mean, they are not, if these little clinics in these little areas are not making money, they're closing them. That's what happened in Somerton.
Greenville.
I would agree with you. I know there's a lot going on up in Greenville, a lot I do not agree with. I think that greed and a lot of other things are playing into it. Anyway, I'm not going to get off on that tangent. There's something was said that I needed to clarify. You talked about, one of you all talked about a doctor and then a PA, which I guess is a physician's assistant, and that they fell sort of under a different arm of the tree or limb of the tree than you all do, and oversaw by different oversight agencies. Explain that to me real quickly, because I didn't know that.
Yes. So nurse practitioners come from nursing. In fact, I'll just tell a quick anecdote. So I was in the hospital, and there was a medical student, and he was really cool. We were talking back and forth, and he says, "Hey, so when you get through?" I'm like, "What do you mean?" He said, "Well, when you get through with nursing school." And I'm like, "Dude, I'm a nurse practitioner." He said, "Oh, I thought that meant you were practicing to be a nurse." So when you don't know what you don't know, sometimes you don't know. Anyway, so the nursing, since we're from nursing, we're under the nursing board, and they regulate us.
Okay.
And we have our own license.
And we have our own license and our own malpractice insurance. If you are a physician assistant, you're regulated by the medical board.
Okay.
So we have two different people overseeing us.
What about the training of the two?
So the training is, so we have a bachelor's degree, and then we go to nurse practitioner school. So most of us have 2 or 3 years minimum of basic experience taking care of patients, treating patients, seeing disease processes and such. And then we go to nurse practitioner school, which is 2, 3, or 4 years, depending on if you do a master's program or a doctorate program. And you get so many hours of training, because the idea is, hey, you already have had basic anatomy, you've had hands-on experience, so you kind of come out of the gate a little bit, and then we'll teach you the rest. A physician's assistant now has to have a bachelor's degree, and really it could be anything. Most of the time, I think it's now in science, but at one time they could have a business degree. They only had to have so many science credits, and then when they went to 2 years of physician's assistant program. And I like the physician's assistants. I think they're well trained. I have a lot of colleagues that are physician's assistants. And you know what? I collaborate with them as well in certain areas. I don't think they're better trained than us, but 2 years ago, the physicians, the South Carolina Medical Association, moved them ahead of us by allowing them further distance to travel and to also do some of the things that we're asking for now.
Okay.
And in no state, as far as I'm aware, can a physician's assistant practice independently like a nurse practitioner can in 30 that we've already discussed.
Okay, so you meant physician's
Assistant.
cannot or can practice independent, cannot practice.
They cannot.
Okay.
When they first came about, you literally had to be in the same building as a doctor. It's like if they couldn't see you around the corner, you couldn't practice.
Right.
But now they have been moved ahead by the medical practice, whereas nursing has been held back in this state.
So, yeah, you kind of getting brought up here. And who oversees you all now? The
The
nursing?
nursing board.
Nursing board, okay. And the docs and PAs are overseen by the
Yes.
medical,
Yes.
board of medical. Okay.
And the CRNAs, they're under the medical board as well. And there was something else that was misrepresentative. They are not supervised continuously in the OR. I have OR experience. The doctor, the anesthesiologist, can oversee 4 of them. So he can have 4 cases going at one time. He's there for usually induction, which is when you first go to sleep. He's only required to come by there once an hour to sign the chart, to say, hey, is he still asleep? Is he okay? Sign the chart. He doesn't have to come back. So it's not a continuous thing. Even by then, they only have to sign the chart once an hour. He only has to see that patient who is under anesthesia and being cut open by the surgeon once an hour. So even then, they're not continuous like they said.
Thank you.
Thank you. Ms. Barwick. And Ms. Barwick, you did a great job. Tell your husband you're a good public speaker, too. And we're going to close out with 2 physicians, Dr. Hugh Darrence and Dr. Ralph Riley. And I appreciate your gentlemen's patience. And you can testify in whatever order you would like.
Thank you, Senator Davis, Corbin, and Senator Gambrell. We appreciate your time. I'm Dr. Ralph Riley. I'm a practicing physician of 35 years. I have practiced my entire post-residency years in Saluda. That is my hometown. And I grew up on a dairy farm. I figured there had to be something easier than that. I've served on the Medicaid Advisory Committee. I've been active in the South Carolina Office of Rural Health, president of the South Carolina Rural Health Association in the past, and presently on the board of the South Carolina Office of Rural Health. I want to relate a little bit more of a personal history in order to give some validity to a point I want to raise later. Approximately 26 years ago, I believe, NP obtained prescriptive authority, and I called and Stephanie Burgess, and I'm very grateful that she sent to me the very first day that we practiced. MPs were allowed to practice with physicians. Molly Danley and I practiced together for 22 years. And I can honestly say we're very close friends, and she is the closest colleague that I have practiced with in my career. I'm quite appreciative for her, as well as all the other NPs that I have practiced with in the past. There have been multiple. I want to rate, I'm telling you this because I believe that the legislative members have unintentionally been given the impression that the predominant model in the state of South Carolina between MDs and MPs is a physician requiring compensation for oversight, but basically giving nothing of value in return. These stories and testimony, frankly, disturb me as a physician and the physician community. I feel empathy for the nurse practitioner, and frankly, I feel some empathy for the MD because he's missed out on a valuable relationship, and the patient themselves have missed out on an opportunity. We benefit the patient and the system by being a team. I presently work with NP in my family medicine clinic and I have two MPs that work in just recently in skilled nursing facilities. With the NP in my office, we are literally steps apart. We communicate constantly. We see patients together at times. Not all of them, just the diagnostic dilemmas. We review EKGs, we review x-rays when needed. The NPs in the nursing home, we communicate constantly throughout the day. When I'm in the facility, several days a week, we see patients together. I see my own. I see patients in follow-up that they wish me to see that they're having difficulty with. It's a team. Second, regarding distribution, I've given to you a map of the state of South Carolina that basically shows the distribution provided by the Graham Center in Washington. It shows the distribution of NPs and MDs to be almost exactly the same. In fact, I think if you look closely, you'll see there's just as many or more MDs serving in rural areas as NPs. Third, I want to address some of the points raised by some of the previous speakers for this bill. This bill does change the supervisor relationship between a physician and an NP. Collaboration as defined is a verbal arrangement only with one or multiple physicians, as I understand it. I am unsure if we're not auditing supervisory relationships now, and apparently we are not, then how do we possibly audit a verbal arrangement? The best person to decide the capability of an experienced NP versus a new NP is at the local level, not by a subcommittee or a set of regulations. By far, the predominant arrangement in our state is an NP and MD working side by side in the same office. During the day, we see difficult cases, as I have previously described. We discuss treatment preferences. We discuss a lot of things, even some non-medical. I personally do not think my practice is unique. In my vast experience in the rural community, most MDs and most MPs practice the very same way I do. Most of the MPs that I speak with don't want to lose the capability to have the MD side by side, any more than I would love to have a second opinion of an MD beside my side, and frankly, the MP challenges me at times. We learn from each other. Much to my dismay, the future system seems to be the practices owned by larger entities, whether it be FQHCs or whether it be large hospital systems. Frankly, again, to my dismay, we're both going to be employees. Even hospitals, however, and FQHCs put clinics in smaller communities, and most of those have MDs and MPs in those facilities when it is warranted, depending on volume. Recently, the South Carolina Primary Care Health Association, representing FQHCs in dealing with both MDs and MPs, came out in opposition to this bill. Fairly qualified health centers are rural. Given this, we understand and we hear the testimony of the NPs. We realize there are unique situations in areas where none of the models of which I just described are possible. We understand that. We certainly don't, it is certainly not our mission to prevent an NP going to a community that otherwise does not have a health care provider. It is not our desire, especially being a rural physician, to see any practicing quality medicine at low cost to be closed. With this in mind, the physician community has discussed various ways to address this issue. I believe Dr. Durance is going to discuss in more detail the task force to help arrange physicians to properly oversee NPs and assist them in the care in a rural community. To show that we are part of the solution, we support S.351 to increase preceptors to train NPs and MDs. We strongly support the Rural Health Initiative that this very Senate has arranged with the USC School of Medicine. We want to be part of that solution. We support the statewide telehealth network. We support the Joint Commission that has been set up by LLR to allow for exemptions to the radius, exemptions to the number of NPs that can be supervised. Dr. Guest testified that he could not hire a physician, could not oversee someone past 45 miles. The Joint Commission handles that, and it's not made up of just physicians. It's made up of representatives from both the nursing board and the medical board. We do not want a two-tiered health system in South Carolina, and we do not want less in the rural area than we have in the urban area. We have talked often in testimony in today as well as last week about healthcare outcomes. Rural areas already score lower on 70% of the factors that actually determine outcomes. It really has nothing to do with either one of us. 70% of healthcare outcomes has to do with education, income levels, transportation, number of smokers, hint, increase the cigarette tax, obesity, just to name a few. But the physician-led team is best equipped to handle these problems. The physician and the local providers are the best to determine what is the highest quality at the lowest cost. In summary, first, we feel that the predominant model is a close relationship between NPs as now practiced in most areas. The MDs learn and gain from the NP. It's not a one-way street. It's a constant field of learning. At times, the NPs challenge us in our thought process. We both learn together. I would certainly hope that the NPs would think that they gain from the MD. The patient gains with oversight, and finally the system for which this state is a major payer gains through lower costs and quality. Most importantly, and in summary, a good team beats a great physician or a great NP anytime in costs, improved value, and improved safety. I want to address just a few points raised by the members of the subcommittee. I think it was Senator Corbin, and I believe he's just left, that addressed the issue if a nurse practitioner was paid to go to a rural area. AHEC currently gives $10,000 for a 4-year period for NPs to practice in a rural area at the present time. I think it's award-based and a scholarship. Regarding who you would want to see, Senator Davis, an NP or an MD, totally agree with you. However, primary care is not as easy as it seems, okay? Sometimes the epigastric pain is an MI, and there have been days in my office where 2 MIs on separate occasions in the same day have been sent to Providence by helicopter out my back door. We never know what's going to be there. And it seems to me that it would be helpful to at least have the most expertise that any given locale can muster. Again, I appreciate your questions and your points, and I'm willing to entertain any questions at this time.
Thank you, Dr. Riley. That was very informative. I truly appreciate it. you said Dr. Durance was going to talk a little bit more about some of the things that have been worked on collaboratively, so we'll hear that and then maybe ask questions of both of you when you're done. Thank you, sir. Dr. Durance.
I'll try to keep this very brief. Chairman Davis, Senator Gambrell, thank you very much for the ability to speak today. Thank you for your time. My name is Hugh Durance. I'm a board-certified family physician. I'm the current chair of the South Carolina Academy of Family Physicians, and I practice in Charleston. I began my career as a pharmacist, and later I still maintain a pharmacy license as well as a medical license in this state. And later I chose to go to medical school so I could broaden what I was able to do for my patients. I'm very familiar, because of my background, with different skill sets of different providers, and while I respect them all, they are not interchangeable. I could give statistics on the significant difference in education and clinical experience of physicians and APRNs, but I'm sure the subcommittee now understands that. I strongly agree with Dr. Riley's observation that the practice models you heard discussed at last week's hearing do not in any way resemble my practice. I currently supervise 1 nurse practitioner and 2 physician assistants in a PCMH Level 3 practice. I have supervised 6 nurse practitioners in 19 years of practice. I also precept students, including pharmacy students. I believe it's part of my responsibility as a physician to give back, to work with and precept non-physician providers so that they can safely work to the extent of their education and training. Quality of care and patient safety must remain paramount. My daily experience continually reaffirms it is best for the patient to be cared for by a team with strong physician leadership, as Dr. Riley has said, and support for each of the team members, support for each other. This past weekend, our academy met to discuss a number of topics, but a major topic of discussion was how to more effectively work with our APRN colleagues. We came to basically 2 conclusions. First, it is unacceptable that APRNs in non-traditional settings are unable to find physician supervisors to work with them. As I said earlier, we do not want anyone providing good patient care to stop practicing. Second, it is unacceptable if physicians who agree to supervise the APRNs do not fulfill their responsibilities to truly have a working relationship that supports the APRN. So our academy and the South Carolina Medical Association are working to establish a group or committee to help develop a registry of physicians who are willing to supervise APRNs with whom they do not have an employment relationship. We would certainly look to work with other potential partners in this effort, such as the South Carolina Primary Healthcare Association and the South Carolina Office of Rural Health. We would also look to work with the Joint Committee of the Board of Medical Examiners and the Board of Nursing if expansions of things like ratio and radius are needed. Finally, the Academy stands ready to work with APRNs on statutory adjustments to the physician to APRN ratio and the geographic radius, as well as some level of authority to prescribe Schedule II controlled substances. We've already offered to make the same changes that were agreed to with physician's assistants in 2013, which passed both the Senate and House unanimously. That approach was not acceptable to APRN leadership, but we would look forward to continuing to work on those issues.
And I think that's a great way for us to end today's testimony with that willingness to sit down and talk about areas where there's potential common ground and in regard to radius, in regard to ratios, in regard to scope, in regard to prescriptive authority, things of that nature. I think what I'd like to do at this point in time is adjourn this subcommittee meeting and continue into a further date, taking up the bill. And in the interim, I would ask the stakeholders to contact me and perhaps other members of the committee if they'd like to sit in, so that we can start to have those sorts of discussions to at least explore whether or not some sort of a consensus or an agreement can be to explore it. I'm not saying that we can reach it or not, but I think it's important to have that conversation. I will say that last week's testimony and this week's testimony, or tonight's testimony, from both sides has really given me an understanding of this issue that I did not have. And so I really appreciate everybody who took the time and waited to testify and give their testimony, because it's helped me tremendously in terms of trying to find an area of agreement to improve healthcare outcomes. I think everybody has the same objective. And for what it's worth, based on what I've heard, I think that there is some ground there. So with that, I will go ahead and call an end to this subcommittee meeting, and then I will work with the group's various representatives on subsequent meetings to be held to discuss those matters. And thank you all again for your patience and for coming.